Welcome to CRT 2020. I'm Ziad Ghazal from the American University of Beirut, and I'm joined today by Dr. David Cohen from the University of Missouri. We're going to tackle today the topic of anticoagulation or antiplatelet post-TAVR. So David, tell us first, what is the evidence and what are your thoughts on valve thrombosis post-TAVR? What do we know?
Yeah, thanks, Ziad. Valve thrombosis is something that was identified as an incidental finding on some CTs several years ago. I think the first person to identify it was Raj Makkar, and there have been several publications on it. And now that we recognize this as a phenomenon that we see in our patients occasionally with TAVR, the question about it has always been: is it just an imaging finding? And something that has always been there and we just didn't know about it? Or is this something pathological, something that is causing complications? And that's been challenging to study. The things that we know is that with TAVR, regardless of what valve type you use, and even with surgical aortic valve replacement, a certain proportion of patients will get an asymptomatic leaflet thrombosis, sometimes with restricted motion. The acronym for it nowadays is HALT, is what it's called. But the clinical consequences are unknown. Some of these patients will have TIAs or strokes, but the association has been relatively weak. There is some observational data in the literature that we can prevent it by use of anticoagulants, because what has been seen in the observational studies is that patients who were receiving anticoagulants for another reason, like warfarin or a DOAC, had less of the valve thrombosis than patients who were treated with traditional dual antiplatelet therapy. So it's a phenomenon.
So this was observational. Have we moved to scientific data? We have recently. Can you tell us more about that?
So because of concerns that these thrombi could lead to strokes or perhaps to accelerated valve degeneration, there's been an interest in trying to determine, can we prevent it, and if so, what would the benefit be? And so the first real study designed to test that is the Galileo study. This was actually presented more than a year ago at the TCT, and then just published back in November of 2019 in the New England Journal of Medicine. And this was a nice study, about 1,600 patients after a successful TAVR with whatever valve, who had no indication for anticoagulation. So these were not atrial fibrillation patients; these were standard TAVR patients of all across the risk spectrum. And then they were randomized to getting conventional dual antiplatelet therapy, aspirin and clopidogrel, or to getting rivaroxaban in a low dose, 10 milligrams a day of rivaroxaban, not 20 like we usually use for atrial fibrillation, 10 milligrams a day of rivaroxaban with an antiplatelet agent, either aspirin or clopidogrel for the first 3 months, and then just rivaroxaban after that. So really testing the hypothesis, could we prevent valve thrombosis with an anticoagulant? And if so, would it translate into clinical benefit?
And as far as giving the rivaroxaban, this was for, so how long was the duration?
So it was a event-driven study, so there was no specified duration of it. I think in the end, the trial was actually terminated early because of safety concerns.
So what were the safety concerns?
Safety concerns was mortality. So what was seen on the clinical, so the good news is that rivaroxaban worked in terms of preventing valve thrombosis. There was a very substantial reduction in the incidence of CT-detected asymptomatic valve thrombosis in the patients treated with rivaroxaban. The problem is that the harm outweighed that benefit. There was excess bleeding across a variety of different definitions, perhaps not a surprise, giving a more potent anticoagulant. But most importantly, there was excess mortality. A statistically significant, about a 50% relative increase in mortality over time with rivaroxaban, which led the trial to be terminated, and certainly is a big concern. So can we prevent valve thrombosis? Yes, we can. But so far, we don't have an answer for how to prevent it safely that would benefit our patients.
So now take us back to your practice. How do you manage patients post-TAVR in terms of, now we're left with antiplatelet agents? What do you do?
Well, so first of all, some patients after TAVR do get anticoagulants, if they have another indication, atrial fibrillation, a mechanical mitral valve, whatever that might be. In those patients, we treat with standard anticoagulants, either a DOAC or warfarin. But for the standard run-of-the-mill TAVR patient, What we have been doing at Mid-America for the last 2 years is single antiplatelet therapy, except in one circumstance. So the exception is if the patient has a clear indication for dual antiplatelet therapy. They've recently received a drug-eluting stent. Those patients will get dual antiplatelet therapy. But for everybody else, we go with single antiplatelet therapy because dual antiplatelet therapy is not benign in these old, sick patients who are getting TAVR. We know that it's really just as risky as giving an anticoagulant, and right now we have no evidence that it's beneficial. Right. So when we have no evidence, if it is beneficial, we'll start giving it again. But for now, we have gone to single antiplatelet agent. In most cases, just aspirin.
Right.
For these patients.
What is the standard of practice these days? I mean, some people still go for clopidogrel for a duration of a few months.
I think we are the outlier. I think most places will still give 3 to 6 months of dual antiplatelet therapy followed by single antiplatelet therapy.
Right, and of course you can look at the bleeding score and decide accordingly if you want to go.
If you want to be technical about it and quantitative about it, yes. But I think it's, this really comes back to the principle of, we started using dual antiplatelet therapy when TAVR started back, in 2007, 2008, because we thought it made sense. That's what we use with drug-eluting stents. But we have to remember that the evidence that it actually benefits the patient doesn't exist.
Right.
And so if there's clear harm and there's no evidence of benefit, we should probably avoid doing it.
And many a times we are dealing with an elderly population.
Right.
So obviously it's taken into consideration. And I guess my last question is, what if you have a patient on NOAC or warfarin for an indication such as atrial fibrillation? Do you keep them on that alone, or do you add your aspirin?
No, there I would, we know there really is no indication to add an antiplatelet agent. Again, outside of the setting of early after stenting,
right,
to a NOAC or warfarin.
Yeah.
All that does is add risk. We've seen that in the Augustus trial for atrial fibrillation, that adding aspirin on top of a NOAC to these patients, regardless of whether they have coronary disease or a recent stent, once you get, just for this period of the stent, after that, single anticoagulant therapy is the way to go. The one other, the other question that still is interesting, not addressed at all by Galileo, is what do you do if you do detect a thrombus on the valve? In those cases, again, those are the places where we do add an anticoagulant because we know we can resolve it.
Most of the time, you would detect it coincidentally.
Right, or we do see it sometimes where the gradient goes up. On their 1 month or their 1 year echocardiogram, and then we do a detailed assessment with TE or a CT. We see thrombus on the valve. If the gradient is high, we're going to treat with that with an anticoagulant, at least until it resolves.
I think everybody would agree with that. Dr. Cohen, thank you very much.
My pleasure. Great to be here.
Extremely helpful.